Ulitin ko pa, gusto mo lang akong galang sa admit. That's why I really wanted to access the kailan taon na siya. Mm. Yun, well, tapos ilang taon na po siya.
Hi, sir. Teka, tingnan natin siya. Yes, we can start na po. Ay, live na pala ako. Ano, boss?
24,
Good morning, everyone. Welcome to our webinar for this morning. It is entitled Epidemiologic Principles of COVID-19 Response. So before I introduce the speaker, I'd like to present to you first what our objectives are for this session. So our general objective is to present the parameters used by the national government in monitoring and evaluating the response to the COVID pandemic. So one, we will introduce basic epidemiologic terms as parameters in monitoring the COVID pandemic in the country, present definition and a basic explanation on how case doubling time is computed, present definition and how critical care capacity is computed. Number two, we will discuss the criteria used in classifying LGUs based on outbreak risk level. Three, present the classification methodology for determining actions for disease mitigation. Number four, discuss the process of case validation. Number five, discuss mechanisms, rationale, and implications of new daily case reporting terminologies. And lastly, address limitations, challenges, and ways forward in the COVID response. So at this point, I would like to introduce our two speakers. If you have any questions, please don't hesitate to type them in the chat box or upload them on Facebook Live, and we will get back to you after the two speakers have finished their talks. So I'll introduce the first speaker. Our first speaker obtained his degree in medicine from the University of the Philippines in 1985 and his master's science in epidemiology with the highest academic achievement from the same institution in 1999. He has had over 30 years of experience in epidemiology, biostatistics, health financing, community health, program management and evaluation, and health system management. And he has worked with various local and international health organizations, including the DOH, PhilHealth, Management Sciences for Health, the Bill and Melinda Gates Foundation, USAID, World Bank, UNICEF, and ADB, among others. He is also multi-awarded. In 2016, he won the Rue Prize awarded by the Institute for Health Metrics of the University of Washington. He's only the third awardee ever and the first Filipino to do so. Currently, he chairs the Drug Price Advisory Council, which drafted the executive order on maximum drug retail prices. He was part of the Formulary Executive Council of the DOH and of the Technical Working Group for the drafting of the Philippine Universal Healthcare Law. He is also a co-founder and current president of Epimetrics, a public health research firm where he continues to work with DOH, IHME, and USAID, among others, in reforming the health system while training and working with young researchers in public health. So our first speaker is Dr. John Wong. For our second speaker, she is known to everyone. She is the current OIC Undersecretary of Health and was previously Assistant Secretary in charge of the Public Health Services team. She previously served as Director of the Health Facilities and Services Regulatory Bureau and Chief of the Health Research Division of the Health Policy Development and Planning Bureau. Undersecretary Vergere has committed decades to public service, having worked in Marikina City's health office before joining the Department of Health in 2007. She obtained her undergraduate degree in zoology from UST, her Doctor of Medicine from De La Salle, and her Master's in Public Health from University of the Philippines, Manila. So our second speaker is Dr. Maria Rosario Vergere. So at this point, I'd like to call our first speaker, Dr. John Wong, to take the stage.
Thank you, Dr. Biror, and good morning, everyone. I'll share my screen.
Volume.
Okay, sir, you may proceed.
Okay. Can you see my screen? Can you see my screen? Can you hear me?
Yes, sir, we can see your screen.
Can you hear me clearly? Can you hear me clearly?
Yes, sir. Yes,
Okay,
sir, we
thank you.
can hear you.
Okay, so this morning, I'll present to you the local government unit epidemic response framework that the DOH is using to help LGUs respond to the pandemic. No? So this framework was developed by Epidemiologic. So we use two indicators, no, to monitor the epidemic. No? This is case doubling time and critical care utilization rate. No? I'll explain in a while what they are and how they are computed. No? So we'll also discuss how we use the framework to classify LGUs according to outbreak risk level and what the recommended actions or responses we give to the LGUs. Okay, so we use there are actually many indicators we monitor, no? But these are the two main indicators that we use to classify the risk levels of each LGU. So by LGU, we mean here provinces, highly urbanized cities, no, like the cities in Metro Manila, and independent component cities. So first, case doubling time. No? So what is case doubling time? No? So CDT is a measure of the speed or the growth of the outbreak. No? It's important because it tells us how effective our outbreak control measures and prevention measures are. No? So if our measures are effective, we should expect the CDT to slow down. No? So it influences decisions on case finding, testing, contact tracing, isolation, and quarantine. No? So this is an output or outcome indicator that measures how effective LGUs have been in doing these activities. No? One thing we have to note that although we have a lot of cases, no, the epidemic is mainly centered in NCR, no, with also a lot of emerging cases in Cebu and also in Davao. No. For the CDT, our data source is from the data set of the Epidemiologic Bureau in DOH, no, their case listing. It's also from the FASTER dashboard. The FASTER dashboard is a DOST online dashboard project that they developed or is developing in coordination with Ateneo. No? So all these tools that we developed, designed and developed for DOH, no, are displayed in the FASTER dashboard. No? So how do we compute CDT? No? So this is a bit technical, no? But I'll share with you an Excel sheet or a Google sheet that you can use if you also want to compute your CDT in your own LGU. No? So it's computed as the day number of the epidemic. No? So for example, we're almost at 100 days of the epidemic, no? Divided by the log of the total cases on that day, no? To the base 2. No? So you don't have to worry about the formula. No? If you use the Google sheet, which is hyperlinked in that phrase below, no? You can just input the total cases, no? And your CDT graph will automatically be generated, and CDT will be computed. So how do you interpret CDT? No? So high numbers. No? So for example, if we have a CDT of 30 or 30 days, no? This is a slow outbreak. No? and are better. No? Low numbers, on the other hand, indicate a fast outbreak, no, and are worse. So if your CDT is 7, no, that means your cases are doubling every 7 days. No? So this is very bad. No? So we measure CDT at the national level, at the level of highly urbanized cities, and at the level of independent component cities. No? And it is measured daily, no? With each additional case. No? However, one caveat about interpreting CDTs is that when the number of cases in your city or province is very low, no, let's say 10, no, or 20, no, automatically your CDT will be very low, meaning your doubling time will be very fast. No? It's only because of the small numbers that you have. No, it's very fast to go from, let's say, 5 cases to 10 cases in a matter of 1 or 2 days. No? So your CDT may appear like it's going very fast. So when your number of cases is very small, no, interpret this with caution. No? So CDTs usually work when your outbreak is quite large already. So this is how we display, no, the case doubling time. So in this graph, the number of days since the first case, no, in the outbreak is graphed here, no, on the x-axis, and the number of patients on the y-axis. And then this is cumulative number of cases. No? So every day's case is added to the previous day's cases. No? So here we see in the blue line, no, the case doubling time. No? So as the cases accumulate, no, over days, no, the line starts to go up. No? So this graph is read like a speedometer, no, of a car. No? So flat lines, no, are slow outbreaks. No? So this is a 30-day doubling time. No? So cases go from, let's say 100 cases to 200 cases in a matter of 30 days. So this is very slow. However, this is a very fast outbreak. No? Steep lines are fast outbreaks. No? So this is a 3-day doubling time line. No? So it goes from 100 to 200 cases in just 3 days. No? So at the national level, our outbreak started actually very fast. No? As I said, no? Small numbers, no? CDT is very fast. No? Maybe 1 to 2 days. No? At around maybe the 30th day, no, of the outbreak, it started to slow down. Okay. The green squares here are where we applied ECQ. No? So this is March 16, no, when ECQ was initially applied. But there's a lag time, no, a latent period, no, before ECQ starts to be effective, and this is it, no, April 1. No? So we see that at April 1, no, the line started to flatten, no, or curve, no. So since then, no, it has been almost flat now with a slight incline, and just recently, it has slowed down from 3 days to just 7 days. No? So cases are still increasing, but the doubling rate has slowed down to just 7 days. No? The red line is doubling time, but for death or for mortality. No? So here we see that deaths actually slowed down much earlier than cases. No? And very early on, it has already flattened. No? So there are very few additional deaths now, and most of the deaths now are outside NCR. Okay, so this graph shows the speed of the outbreak now for both cases and deaths now, at the national level. No? So this is a series of 4 graphs now, showing the doubling times in different geographic units, no? NCR, Luzon, Visayas, and Mindanao. No? So we noticed several things here. No? That the scale of the outbreak is very different, no? In each area. In the tens of thousands in NCR, in the rest of Luzon, it's only about thousands. No? in Visayas, no, it's approaching the tens of thousands, although still less than 10,000. But in Mindanao, it's only in the hundreds here. Okay. The second thing we notice is that for deaths, no, for mortality, although all of them have already gone beyond the 7-day line, no, they've slowed down. No, but it slowed down very early in Cebu. No, on the 25th day, it was already beyond the 7-day line. No? So what's significant about Cebu is that although it has a lot of cases, no, and it only recently slowed down beyond the 7-day line, very early on, it has already had very low mortality. No? Same for Mindanao. Actually, in Mindanao, no, it's a very small outbreak with very slow doubling times and even slower deaths. No? There are very few deaths, no, in Mindanao. No? So here we conclude that the NCR was actually the epicenter of the outbreak. No? Maybe about 70% of the cases, no, are from NCR alone, no, plus its neighboring provinces. Let me go back. The other thing I have to point out here is that in the y-axis, now we graph it using a log scale or a logarithm scale. No? And the advantage of using a logarithm scale rather than the usual arithmetic scale is that for every increment, no, every 1 unit increment, no, you know it increases 10 times. No? So from this level, no, to this level, you know the cases increase 10 times. No? So from 10 to 100 cases, no, in just a few days. Okay. So some people have said that because we use the logarithm scale, lines will always curve. No, and this graph shows that that's not true. No, here we have the Philippines compared with a lot of other countries, and it shows that for other countries, no, if there are epidemics out of control, the lines can continue to go up, no, and it curves only when the epidemic slows down. No, so here in the Philippines, we're actually, although we have quite a lot of cases, no, we're actually doing pretty good. No, we're in the middle of the pack. No, we're not the worst. No, we're not the best. No, we're just right there. No, in the middle. This is an epidemic curve. No, although we don't use it to classify LGUs according to risk level. No, this is also a good way of monitoring the outbreak. No, so this graphs the number of cases per day. No, it doesn't show the growth, no, or the speed, no, just like the doubling time, but it shows the magnitude of the number of new cases every day. No, recently, about May 31, no, there was a dramatic increase in cases, no, about 1,000 cases, no, from the previous day of about 500. No? So a lot of people were actually quite shocked with this, no, that they were thinking that did the epidemic actually worsen? But what actually happened was that the DOH has shifted to a new data collection system. No? They call it the COVID Kaya app. No? And because of this better increase or improved reporting, there was an improved or increase in reporting of backlog cases. No? So here we see it that these are the new cases, no? Still quite low, and the blue bars are the new cases. So a lot of them are late cases that were just recently reported. This is the same graph as a while ago, which shows a dramatic increase. No? But if we adjust the cases to their actual date of lab release, no? So move these cases backwards, no? We see that although there was a rise, no, it's not as dramatic as we have actually saw. No? So most of the line is still flat, no, with a slight incline or slight increase, no, in cases. So this is what the epidemic actually looks like, no, if we adjust for reporting dates. No? Although we see that there is a recent increase, no, in cases. So one way we monitor this is we draw a median line. No? So this is the median number of cases, about 245. And then this is the 75th percentile line. No? So if the number of cases exceeds the 75th percentile, no, it's a sign that cases are increasing significantly and that we should do something. No? So we have to remain vigilant, no? Because it's above the 75th percentile line. What about for deaths? No? What's happening with regards to deaths? No? So after a peak of 50 days, no, the number of deaths every day has gone down below the 75th percentile line. It's gone down much further. Again, with improved reporting, no, there was actually also a rapid one-day increase, no, in cases, no, to 22 deaths, no, per day. No. But again, no, this is due to improved reporting. No. So if we look at date of death rather than date of reporting as a death, no, we see that deaths have continued to go down. No? So right now, the median is about 9 deaths a day. Another way we monitor the epidemic is to look at R0, no, or the basic reproduction number. No? So as you all know, the basic reproduction number measures the number of secondary cases an infected individual can transmit the disease too. No? So R0 is usually computed after the epidemic. No? In the middle of the epidemic, we compute a proxy called the time-varying reproduction number, no? Because it changes every day. No? So when the pandemic started, it was about maybe 3.6 at its peak, no? But that has since come down. No? And it continues to be near 1. No? So we're confident that the outbreak is still under control. No? It's still continuing, no? Because each case is still transmitting it to another case, no? But it's not as high as before. Okay, so before I talk about the critical care utilization rate, no? Let's talk about what it means when we say the curve has flattened. No? So this would be the shape of the epidemic curve, no? If we did not apply any control measures. No? It would just go up, no? Exceeding the capacity of the healthcare system, no? To control it. No? So we can measure healthcare capacity in terms of number of ICU beds, isolation beds, or mechanical ventilators, no? Or the things we need to manage severe and critical cases. So in order to avoid this unfortunate situation, no, we apply control measures so that instead of going up this rapidly, no, the increase is more gradual. No? In the end, no, we may still have the number of cases, as you see, no, this is wider. No? We may still have the number of cases, but the rate of increase is well within our capacity, no, to take care of patients. No? So here you see a slight gap. No? This is the reserve capacity of critical care. No? Okay, so on this basis, the other indicator we use to measure or monitor the outbreak and to classify LGUs is the critical care utilization rate. No? So what is this? No? This is the measure of the percentage of critical resources that are being used or occupied at any time. No? So we measure three resources: mechanical ventilators, ICU beds, and isolation beds. No? So if they are occupied or being used, no, we compute the percentage of utilization. No? So how do we interpret this? No? Or why is it important? No? Low utilization means there's high reserve capacity. No? They're inversely proportional. No? And high reserve capacity means you have surge capacity in case your cases suddenly increase. So what we want is low utilization capacity so that we have high reserves. No? So this is influences our decision on what we need to do, no, to increase hospital capacity and also influences our decisions on the timing and severity of lockdowns. No? So lockdowns are an extreme form of quarantine. No? You enforce reduced contact among people, no? So that the number of cases can, or the rise in the number of cases can slow down. No? So we also get this from the DOH data collection system called data drop. And how is it computed? No? So we compute the utilization rate for the three resources: no? ICU beds, isolation beds, and mechanical ventilator. No? And we choose the resource with the highest utilization rate, no? Because that's the rate limiting factor. So low numbers indicate high reserve capacity and are better, no? And vice versa. For CUR, we measure it only at the regional level, no? Because at local levels, no? Cities and municipalities, no? Not everyone may have ICU beds, no? Or ICU rooms or units. And provincial, they may not have enough capacity. So we use the DOH regional hospitals, no? as backup or surge capacity. It's computed daily, no? Through the app. No? However, even though this is measured at the regional level, the DOH continues to encourage provinces and cities, no? To increase their own supply of ventilators, ICU beds, and isolation beds. No? Because not doing so means they're always dependent on regional capacity. No? So if there are pandemics or outbreaks in other provinces, no? One province that does not have an outbreak may be classified as moderate or high risk, no? Just because their utilization rate has gone up. Okay, so this is the actual CDT numbers, no? In terms of days, number of days, no? So as we said, no? High CDTs are better, no? And low CDTs are worse, no? So at the national level, no? We started, I think this was March 16, no? March 16, with a CDT of 2.5, no? So every 2.5 days, no? The cases were doubling. Right now we're almost at 7 days, no? So it has slowed down considerably. So we see a slowing down of the outbreak, no? Across all, no? All geographic units, no? So NCR was the last one, no? To cross the 7-day line, no? The outbreak is lowest in Luzon, no? And also in Mindanao, no? Visayas improved very slowly, no? Because of a couple of clusters, no? In their prisons and hospitals and communities. This is mortality doubling time. So again, no? Mindanao doing the best, no? Followed by Visayas and Luzon, no? NCR is not doing badly also. Okay. So using these two indicators, how do we classify LGUs according to risk levels? No? So we use this framework. No? This is based on the CDC's pandemic interval framework. No? So at local levels, so we have to remember that outbreaks always happen locally. No? So what we have now in the Philippines is not a national outbreak, but several asynchronous localized outbreaks. No? So they have to be measured at the local level. So in the recognition phase, no, we recognize the introduction or importation of cases of a case. No? At the initiation phase, no, we start to have a few cases, no, but most of these cases are secondary cases from the imported case. No? In the acceleration phase, no, we start having community transmission or transmission from one local case to another. No? This will peak at a certain point, no, depending on our response measures, and then it will start to decelerate. No? When it reaches a very low level, no, we say they're in the preparation stage because without a vaccine or an effective treatment, a surge is likely to happen again. So they're just preparing for the next surge or next wave. So we have two indicators, critical care utilization rate and case doubling time. So as I said before, the limitation of case doubling time is if the outbreak size is very small, the CDT may appear to be very fast, and that gives an overestimate. So first we set a threshold. For provinces, we start computing CDT only after it exceeds 25 cases. For highly urbanized cities, the threshold is 15. For ICCs or independent component cities, it's 5. So for LGUs with very small outbreaks, we just use critical care utilization rate to classify them. So we have set two lines. If the utilization is less than 30, this is low risk. If it's 30 to 70, it's moderate risk. If utilization is more than 70%, it becomes high risk. And then if utilization goes down again, it goes down to moderate risk and then to low risk. However, when outbreak size exceeds these thresholds, we start using both indicators in these combinations. So for CDT, we use 7 as an initial cutoff. 7 to 30 for moderate risk, and greater than 30, or a slow outbreak for low risk. So we combine all of this in a matrix that allows us that this is what we use to classify LGUs. So depending on first their outbreak size, second their utilization rate, and then third their doubling time, we're able to classify each LGU according to different phases. Okay, so this is how an outbreak would look like. So when you have a first imported case, this is the recognition phase. When you start to have more cases, initiation phase, and then you have the acceleration phase, the increasing cases. So right now, at the national level, and even NCR, we're in the acceleration phase now. And then when your outbreak slows down, you're in the deceleration phase, and then you end up in the preparation phase now. So the risk levels are classified this way according to the phase of your epidemic. And each phase or each risk level corresponds to a certain strategy. So when you're at low risk, you don't need to impose a lockdown or community quarantine. You can still contain the outbreak by testing, isolation, contact tracing, and quarantine. When you're in the initiation phase, your risk level is moderate. In addition to containment, you may choose to do mitigation. So mitigation includes the non-pharmaceutical interventions of hand washing, physical distancing, wearing face masks, frequent cleaning of high contact surfaces, and may include school closure. When you're in the acceleration phase or high risk phase, this is when ECQ becomes necessary, because your number of cases have run out of control. When it starts to slow down, you can step down to GCQ, and then when you're in the low phase again, you continue to prepare your health system capacity, your public health capacity for the next surge. Okay, that's the end of my lecture. Thank you.
Thank you, Dr. Wong. I hope you can stay for the Q&A later. So at this point, we would like to call our second speaker, Undersecretary Dr. Vergere. Good morning, ma'am.
Yes, good morning, sir. Magandang umaga po sa inyong lahat. Good morning to Dr. John Wong. I will be presenting for today the changes in the way that we are reporting cases for these past weeks. Can we share the slides, Dr. Vince? So as what Dr. Wong has just mentioned in his presentation, we have just changed our means of reporting our cases. I think it has been 3 weeks already from today. Next, please. Next, please. So just like to give this information in this time of pandemic and COVID-19, first we'd like to emphasize that science is rapidly evolving and what we know for today will change maybe tomorrow because of this evolving nature of the disease. So in our reporting systems and the information that we give to the public, there are times that what we have given to the public for today may change tomorrow because of this evolving nature of the disease. Many people make opinions based on the excessive amount of information available. So it has been I don't know if I should call it a trend, but because of all of these different issues in the reporting and the information being given to the public, so there are a lot of assumptions already on what should be and why there are this kind of reporting in our country. The speed of misinformation, particularly the social media, needs to be managed. So aside from doing our exhaustive work in the Department of Health with this current pandemic, we are still managing and trying to handle the misinformation that is also spreading alongside with the different issues in our health sector. But basically, what is driving the issues right now would be this information system of the Department of Health. Next, please. So this slide would show you, if you would see, this is our case bulletin. I know you are all familiar with this. And on the right side of the slide, we'd find a page where we have placed this laboratory result that we issue out every day also alongside with our case bulletin. So you'd find that in our case bulletin, here, the one with the red box or the outline with the red line, we have the total number of confirmed cases which we report every day. And then in our daily laboratory results that we issue in our Beat COVID-19 Today Situation Report, we also issue the total number of unique individuals tested. And this is the 23,843. This is just an example. This is as of May 30. So if you'd find, and I know a lot of you would be having this form of analysis also. Most of the people would try to compare our total positive individuals or total unique individuals tested with the daily confirmed cases. And with that comparison, the difference would be around 6,619. So first, I just like to make mention and manifest that these numbers, these two numbers, the total unique individuals tested compared with the total confirmed cases will never be equal in any given time. Why? Because there are specific individuals that are tested with more than one test, and these are their repeat tests. The second would be based on the different parameters that we use, there are really identified late and fresh cases that we have said. So based on this difference in the numbers and based from how we have analyzed because of this clamor for people asking why these two numbers are not the same, we then went back to our data and saw that really there are cases that has not been reported and has not been added to these confirmed cases of ours. Next, please. So if you see here, the previous bulletin that we issue out would be the total number of cases with the different outcomes for this number of cases, like active, recovered, and died. We have shifted into this new form of reporting, putting in the fresh cases and the late cases, and defining the fresh cases as those number of individuals or number of cases wherein the test results were released within 3 days from the time that we have reported. And then the late cases would be those that are more than 4 days from the time that we have reported. And we were able to report the highest so far for a day of a total confirmed cases at 1,046 during that time. The very reason for this was when we responded to the clamor of specific individuals regarding the unique individuals tested versus the total confirmed cases, we asked all of our laboratories, and this is also as part of us improving our data, we asked all of our laboratories to submit to us their complete line list of these positive individuals since the time that they have started operating. So we did cross-validation, and then we found specific individuals or cases that were still not reported, specific duplicated cases. So we had to clean the data, and we were able to come up with this new reporting scheme so that we can explain very well to people what should be considered as fresh or these newly reported cases, and that people will also consider and be aware of these late cases that has been reported but has been more than 4 days already that their test results were released. So when we try to disaggregate the 1,046 that has been inputted into our system during that day of May 29, it turned out that only 46 were cases which were reported or which were in the results were provided to us for the past 3 days based on that day of reporting. And there were 1,000 late cases or more than 4 days from the date of the release of the result. Next, please. So why did we do this? Again, the rationale. We like to improve the public's understanding on the number of new cases, to provide more real-time status of COVID-19 pandemic. And of course, we like to highlight the importance of validating data and harmonizing with data coming from the lower levels of governance. Next, please. So these are the issues in case validation leading to the delay in reporting cases. First, I just like to make mention about the process whereby we get reports. We get reports coming from the lowermost level of governance or reporting unit, and that is our barangays. From the barangays, they submit to their municipios, or the municipios, they submit it to their provinces. Provinces submit to the regional office, and then that's the only time that it gets to be submitted to the national agency. So if you like, if you try to look at that, there are a lot of layers in our reporting system that these reports pass through. So first, there are a lot of delays because these are things or these are layers that has also daily operational issues. So just want to mention that so that everybody is on the same page in understanding where the reports are coming from. So when you say reporting unit, it can either be a local government unit, it can be a hospital, or it can be a laboratory. So these are the reporting units that we have. When we say it's a hospital, it's going to be disaggregated according to public, private, local government, national government, and the different laboratories also the same, and of course the local government units that we have, which has different reporting units as well. So these are the different units that we get reports from, and hopefully with what we are doing currently, we will be able to harmonize all of this and just have this streamlined process for us. So what would be the issues on why we have these delays in reporting of cases? First, because of the expanded protocols in testing, there is increased testing capacity, and therefore there are more tests that are being done in specific LGUs, therefore increasing the number of cases to be validated. The second, we are very much, we recognize the weakness in our surveillance units because there are really no designated people for surveillance in the different local government units. So we lack these disease surveillance officers to monitor our cases, to encode our case investigation forms, and to upload our data. So what the national government has done now is that we have ordered our regional offices to download money to our local government units so that we can hire additional disease surveillance officers and encoders. And these are all being done already. The third would be the possibility of duplicating cases within our laboratories. For example, encoding error in names. There might be that there are people who has junior or senior at the end of their names. And this, when we try to verify, has not been encoded, but on the CIF, it is there. So we have to go back to that specific person, check if this really was this person, and so that we can already tag them as part of the confirmed number of cases. Sometimes the numbers are also duplicated that it has been reported already with laboratory A, but when they did the repeat test for the second or the third test for these specific individuals, they are also reported by the specific laboratories where they went to. So these are duplications and we need to remove them also so that we won't have a duplicating number of cases. And also, we like to also say that with validation, with this encoding error in the names, like for example, the name is Maria, Maria Rosario, for example. So Maria may be spelled M-A only when in fact the real name is M-A-R-I-A. So when you try to validate based from the CIF and based from the list that has been submitted to us by our laboratories, you'd find two different names. But when you call them, it's just one name and one person. So these are the things what we do and which delays really the validation and the reporting of our cases. Next, please. So this is just the process of validation when we receive the complete line list from our laboratories. So the laboratory has sent us their complete line list of positive cases from the start of their operations. What we did was to cross-validate this with the Epidemiology Bureau's database. This is the DOH's database. So with that, we were able to identify and remove the duplicated entries. So we call this process deduplication. So first, we remove those multiple tests done for one patient. So as I've said, one patient may have more than 5 tests in this period of his illness. So we just try to remove all of those and just count it as one because it is just one unique individual. The second, as I've said, this might be errors in encoding for the names. It might be clerical, or it might be that there has been missed parts of the name that has been missed, so that we need to verify and therefore we need to validate that it is just one person. After removing all of these duplicates, the process of the duplication, we go now to step 3, wherein EB, with this cross-validation, still identifies new confirmed cases that have not been encoded yet into the system before. So in here, in this step 3, we are also identifying newly confirmed cases based from the line list of the laboratory. And the stage 4 is identifying unique positive individuals per lab. So there are different laboratories, we all know that. So sometimes a specific individual is tagged in different laboratories. And that is also one of the things that we try to verify and validate so that we can remove this double tagging. So we tag correctly as unique case first reported by each laboratory. And then we have the tag as having been first tested and reported in another laboratory. So we have to remove this and just maintain one tag for a confirmed case based from the first laboratory that they have gone to for their testing. So these are the different steps that we have done so that we can clean the data from this different line list of our laboratories. Next, please. So this is just an example of the flow chart on how we did the case validation. If, for example, we had laboratory X with 1,000 positive cases, so we tried to cross-validate, the first step would be doing the deduplication. So with this deduplication, we were able to remove those who had multiple tests, and the second, those who had clerical errors in their names. And for example, in this 1,000 positives from Lab X, we were able to remove 200 duplicated items or duplicated from the list. So we are left now with 800 unique positive individuals in Laboratory X. With these 800 unique positive individuals in Laboratory X, we now would be identifying through this cross-validation 100 newly confirmed cases which are previously not in the system of the Epidemiology Bureau. So we have to do that and have to identify these 100, and this will be the late cases from Laboratory X. After removing these 100 confirmed cases which were not previously identified and tagged by EB, we will now have 700 already in our Epidemiology Bureau system. With these 700, we will now look at the different taggings among our laboratories, and we will see that for Laboratory X, we were able to tag 650 because 50 were already tagged from the other laboratories, so we also have to remove that. This might be confirmed cases already reported by Laboratories A or Laboratory B or Laboratory C. So with all of these, we were left with 650 tagged from the Laboratory X. And then we will add the 100 confirmed cases previously not in the Epidemiology Bureau. So we have a total of 750 cases, total cases from Laboratory X. So we started off with 1,000 positive cases from Laboratory X, and we are now left with 750 laboratory total cases with from the Laboratory X. So this is how we do our validation, removing the duplicated items, also identifying newly confirmed cases because it was not identified from the database of the ED system, and also removing those that has been tagged already by the other laboratories. Next slide, please. So the bottlenecks in data collection, as I've said, so just to explain to you how these forms or these reports and information is being passed through one layer to another. So we start off with a patient who has symptoms or maybe asymptomatic. They have to fill out their case investigation forms. The providers has to ensure that the case investigation form will have the complete data. Most often than not, it is the providers which fills out the case investigation forms. Unfortunately, a lot of data or a lot of fields are being left out to be not filled out by the providers. So this is one of our bottlenecks. So after this CIF, they do the laboratory specimen request form, and then they send it, and this test specimen is being sent to the laboratories. Once the laboratory results are out, it is being sent to the Epidemiology Bureau, the regional offices, and the providers which have sent these laboratory samples to the laboratory. And then we share it to the regional epidemiological surveillance units so that they can do their contact tracing. In these different layers of receipts of information, we have identified a lot of issues which stems from the fact that basically the CIF or the case investigation forms are not being filled out properly and timely by our health providers. That is coming from our local government units, our hospitals, and also our laboratories. Next, please. So what we have done so that we can somehow address these problems and bottlenecks in reporting. First, we have already provided assistance to our laboratories for daily submission of their line list. Let me just make mention that the daily line list of the laboratories that they provide the Epidemiology Bureau is very important because this is where we get the fresh cases. So this line list of laboratories, these are the cases or the results that has been issued out 3 days from the date that we are reporting. Also, the second would be the COVID Kaya. COVID Kaya is this automated system of our case investigation form. If only all of our reporting units will be using COVID Kaya, this is an automated system, and therefore this is faster. And once you input into this COVID Kaya, we get it at once in our Epidemiology Bureau, and we can easily and we can hasten the validation of these different cases. So the idea is for us to have COVID Kaya being used by all of our reporting units, and this COVID Kaya is automated and will be able to process all of these reports going up to the Epidemiology Bureau, therefore easing the processes and lessening the traffic in this reporting system that we have. We also have discussed that COVID Kaya will not admit or allow the submission of any case investigation form which have an incomplete list of details. So if the providers cannot provide the complete information, COVID Kaya will not be accepting this submission. So that's another thing. And the third, of course, we need encoders so that our local governments, our regional offices, our hospitals can have people who are dedicated into just inputting information into these COVID Kaya systems. That's why we have hired these different encoders for the laboratories, for the local governments, for the hospitals, and also for the national government unit here in DOH. So this COVID Kaya will improve our accuracy. We will have complete and timely data. And of course, we will be able to remove all of these backlogs in our data validation. So next. So this is just our directory for reliable information sources. We will be sharing this slide to all of you so that for any questions or any materials that you would want, you can get it from here. These are verified and legitimate sources coming from DOH. So that's all. Thank you very much, and over to you, sir.
So ready na. Thank you, ma'am. So thank you, Drs. Wong and Vergere. We will now proceed with the Q&A. So for those who have questions, please type them in the chat box, and I will address them as they arrive. So for Dr. Wong, this is our first question. Maybe just for reiteration for our viewers on Facebook as well. Will there be a significant difference in the computation of case doubling time due to the lags in the release of test results, since the date of the confirmation is the one used to compute for case doubling time?
So we've actually tried to graph epidemic curves and CDTs according to different dates. No? So we have symptom onset date, the specimen selection date, we have lab release date, and confirmation date. So the difference in terms of epidemic curves would be symptom onset date would show that the epidemic started much earlier, no? Followed by the next 3 dates. No? But the shape of the curves are essentially the same. No? It's just that they're staggered, no? But according to lag times. No? In terms of case doubling time, we also did it several ways, and we showed that we saw that there wasn't much difference also, no? Because the duration of the outbreak, no, was a greater factor, no, in affecting the doubling time rather than the number of cases. Thank you.
Thank you, sir. So our next question is for Yusek Vergere. What happens to the test results of laboratories that were not included in the daily DOH bulletin? And a follow-up question also regarding one of the COVID tests. Are gene expert COVID positive results included as confirmed cases? And if not, where can we see the gene expert confirmed data?
Yes, the gene expert COVID tests are part of the test or the confirmed cases, no, that we are reporting. So if, for example, we have a total of 100 confirmed cases, the sources of this would be coming from both RT-PCR and gene expert testing facilities. So gene expert is also an RT-PCR test. The next one would be if what happens to those that has not been reported yet because of these backlogs. As soon as we get the numbers based from the validation and based from this removal of this backlog, we immediately report them and add them to our numbers. So it will just be classified according to fresh or late based on the date of the release of the result of these laboratories.
Next question is for Dr. Wong. I am seeing the recovery line also leaning towards case doubling time of 7 days. Does it mean that recoveries are also slow?
In terms of absolute numbers, no, we've been having consistently 200 plus, no, sometimes almost 300 recoveries per day. But in the doubling time graphs, no, it's not it's not very evident, no, because the the duration of the outbreak, no, again, no, has a greater effect, no, on the doubling time, no. But we do have increasing recoveries.
Okay, sir. Thank you for clarifying. For Yusek Vergere, is rapid testing and/or RT-PCR no longer required to be done on COVID patients who are for discharge? And if so, does this mean that these survivors are no longer infective?
Yes, sir. Actually, there has been this evidence that has been published weeks ago, wherein it states that a person who has been identified or confirmed COVID-19 positive on the 10th day of their illness, they are no longer infectious. And also, this has been supported by WHO, wherein they have issued this publication or report wherein they state the same, that they are now going to recommend the 10 days plus 3 days rule, wherein they say that on the 10th day of illness plus 3 days without symptoms, a person can already be discharged even without having to be tested. When we had all of these evidences, our technical advisory group, our experts have recommended that we already shift from the test-based approach into for our recoveries and discharges to a symptoms-based approach. So we have revised our protocols to state that all of those confirmed positive individuals who are admitted in hospitals or quarantine facilities and who are symptomatic and has not shown symptoms for the past 3 days of their illness from the 10th day of their considering that 10 days you are not infectious anymore, can already be discharged even without a test. Also, for those quarantined individuals who are mild or asymptomatic, when they reach this 10th day and they do not have symptoms, or 3 days, 3 days already that they do not have symptoms from the time that they had their symptoms, they can already be discharged. If you are an asymptomatic and you started off without symptoms and you have completed your 14 days without symptoms at all, you can also be discharged already from the quarantine facility, or if you are in a hospital, from a hospital. So again, I repeat, no need to test individuals who are being discharged. It is now symptoms-based and it should be cleared by the physicians. But everybody has to remember that there is still this 14 days requirement for isolation after being discharged from a hospital or a quarantine facility for all of these confirmed positive patients.
Thank you, ma'am, because that's very important. I think a lot of our viewers are also asking in terms of when they can return from work, and that guidance, I think, is the one that they're going to be used for their companies. Another question for you, ma'am. Do you have data on the utilization rate of COVID Kaya? So, example, how many % of health facilities actually use these consistently?
Yes, actually for now, COVID Kaya's compliance is still low. That's why we are still trying to mobilize our different partners so that they can help us in enforcing this requirement that everybody or all the reporting units has to implement or use the COVID Kaya. We had a meeting with the ILG yesterday and we have asked their support so that local governments will be encouraged, and they can enforce the compliance to this COVID Kaya requirement. We also have included COVID Kaya as part of the licensing requirement and responsibilities of hospitals and laboratories. So it's now part of this requirement for licensing. So when we do our monitoring, the hospitals and the laboratories has to ensure that they are using COVID Kaya so that they can have their relicensing for the following years.
Okay, thank you, ma'am. A lot of our audience are really interested regarding testing, and we'd like to commend DOH for your transparency. So, ma'am, are our testing facilities currently being maximized? Are we conducting the maximum number of tests per day?
Yes, sir. Our maximum capacity, or what we call the rated capacity for all of these 60 laboratories licensed by DOH, is almost 50,000 per day already. When we say it is the rated capacity, we have computed based from their initial licensing. When they were initially licensed, we've computed for their estimated capacity. This is based from the number of their RT-PCR machines, the number of their health human resources, and also the number of operating hours, or the time that they will operate per day. So all of this would be computed as an estimate for their rated capacity. Other laboratories would have two machines. We have a computation or an estimation of how much one machine can produce and how many HR, or health human resources, is needed for a specific machine to operate in how many hours per day. So these were all computed to become the rated capacity per laboratory. Doing all of this and summing it all up for the 60 licensed laboratories, we are almost 50,000 in a rated capacity. But these are not optimized. No, it's not. We are not able to optimize this because when this rated capacity were computed or estimated, the different operational issues have not been considered. So right now, with this rated capacity, we have our actual capacity, and we have not reached, as I've said, we have not optimized rated capacity because of a number of operational issues. The very first issue and major one for us would be logistical issues. This constant need for supplies in the laboratories. We all know that there is this international shortage for the different supplies of the laboratories. That's why we are doing centralized procurement, so that we will be able to have more negotiating power and will be able to source out even from international manufacturers. So we are now trying to provide all of these laboratories with the supplies that they need for their day-to-day operations. The second would be the different health human resources requirements. There are certain laboratories that cannot really optimize their capacity because they still lack the necessary manpower to man their laboratories for this number of operating hours that they intend to. So health human resources still is a factor. The third would be these unforeseen events that has hampered operations of our laboratories for these past months and weeks. There might be this unforeseen event like a typhoon wherein some of our laboratories were affected during the last typhoon and we have to scale down. There would be this affectation of our lab personnel that they will be confirmed positive and they have to leave work, and so HR again will be affected. Also, the third would be the lack of sometimes the need for PPEs which will stop operations because of this. I just like to clarify this. The PPEs needed by our laboratory personnel is different from what we have in the hospital. There is this certain standard by our ITM, which is our National Reference Laboratory, for specific PPEs for our laboratory personnel. Most specific would be the mask. We need a certain type of mask, N95 mask, that has to be used by our laboratory personnel because this is the only mask that has passed the fit test from the National Reference Laboratory. So these kind of issues are bottlenecks, and this hinders our operations and hinders our capacity to reach that or to optimize the rated capacity of all of these laboratories. Over to you, sir.
Thank you, ma'am. I don't think everyone really realizes how complicated it is to perform testing, from having the technical expertise and then making sure that all our testing facilities are safe for the ones who are doing the testing. Our next question is addressed to you both, Dr. Wong and Vergere, and maybe Dr. Wong can answer this one first. What can you advise those from the barangay on where they can access the data to guide them on allocation of logistics and resources for public health advocacy activities? Can they access or should they analyze the data per barangay?
So they can log into the faster dashboard, and it will show you, it will show the number of cases up to the barangay level, no, for the municipality or the LGU where they live in. No? I'll put the link in the chat box. So once they have the number of cases, no, if at the barangay level, except if you're from NCR, but usually at the barangay level, the number of cases is very low. No? So I advise that you draw an epidemic curve first, no, rather than do or compute the case doubling time. So I put the link already in the chat box, no? The link to the FASER dashboard. Thank you.
Thank you, sir. Ma'am, can you also answer the same question? It's addressed to you both.
Yes, sir. Aside from the faster dashboard that Dr. Wong is saying, the DOH, as I've shown you a while ago with my last slide, has different sources of information, which also has disaggregations according to the different levels of government. So, dyan po, you can use this online or platforms, no, that we have so that you can see your data, and therefore you can use it and guide you with your planning in your specific locality.
Thank you, ma'am, and Dr. Wong. We have no more relevant questions at this point. So I would like to thank both speakers for your expertise and for sharing your time with us. And for those who are watching us now, you can still access this webinar in the PCP page because it's going to be saved there after this broadcast. Sasabihin ka. So thank you all for joining the webinar. If you have questions, please don't hesitate to communicate it to the PCP. And then I'd like also to promote our next webinar on June 22. It's going to be on Monday. It's COVID landing on the gut and liver. So at PCP, we try to have webinars involving the different organ systems to be most relevant to our internists and also to the public as well, as you know, since the PCP webinar is open for everyone. So thank you and have a good day.